Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MV Hospital for Diabetes, Chennai. So today's topic is going to be why India is the capital for diabetes. So this could be either it is undiagnosed or it is uncontrolled. I would say both actually contributes because undiagnosed, why I would say undiagnosed is people these days are really scared to go to a doctor. One, they think once they go to a doctor, the doctor is going to brand them with some disease. Two, they think once they get branded with some disease, the society or their family is going to be, looking at them in a very different way. But they just don't understand it is easy or it is much more cheaper to treat the disease rather than spending on the complications due to the untreated or neglected disease. Then, when we say about uncontrolled, most of the people, once they come to the doctor and get their medications, then they are least bothered about checking their blood sugars or maintaining their blood sugars at home, maintaining a self monitoring of blood sugar, knowing when their sugar goes up, when their sugar comes down. They are least bothered. And either they just take the tablet and they are not on a diet, or they skip their medicines, they take it very light, and they start taking things very serious only once they develop a complication. So today we have with us Dr. M.R. Varun Kumar, MD DM, a consultant adult and pediatric endocrinologist, VMC Specialty Hospital, Velamal Medical College, Madurai, who's going to enlighten us on this topic. On to you, sir.
Yeah, good evening, one and all. And at the outset, I would like to thank the team for organizing just a wonderful 4D session today. So, we are discussing here about the under recognized, undiagnosed, the version of diabetes mellitus in India. We will try to see in this very session why we have a lot of diabetes that is coming up in the few recent past, and why we don't have a proper the notion about diabetes, the awareness, the treatment is available, but it is not going into the hands of the people at the right time, right way. So can I have my slides, please? So today we are going to discuss about this undiagnosed, uncontrolled, the reasons of the diabetes mellitus in India. Basically, we are the diabetes capital of the world. We know the prevalence is getting higher and higher by 74% over the next 10 to 15 years duration. So we are seeing an alarming increase in the incidence and prevalence of diabetes mellitus. It is not just the increase in the prevalence, it is actually the distribution is also varied. We have a lot of diabetes coming up at the age of 40s to 60s. Previously, when you say diabetes mellitus, it is around more than 60 years duration of, the age of the people. But now we see a lot of younger generation people having diabetes at very young age with a lot of complications also at the onset itself. So these two problems are going to be, very much maybe like the key factors when we try to take on the treatments, how to decide and how to monitor these individuals. Because when the people are elder and they are getting into elderly age, we are kind of like going back in the skeptical way. We go for a milder control, but when the patient is younger, we try to achieve a greater control. The scenario revolves in such a way that in India, we have people, particularly in the adulthood, 1 in 11, living with diabetes mellitus. Say now we have around 50 to 60 million people who are having diabetes mellitus right now, but it is going to be higher by at least 30 million over the next 15 to 20 years. So it is getting 1.5 times higher. That means the number of people who are living with diabetes is going to be 1 in 10. The number is going to be in a huge number. When you're saying it is 1 in 10, it is 10%. It is going to be a huge number in a total population. Or 1 in 2 of the adults, they don't know that they have diabetes mellitus. They are unrecognized. They don't have the blood workup done, and they don't have the, the idea that they are having diabetes mellitus. The number of people in with diabetes mellitus is getting higher and higher. We may soon become the number one in the world, but as of now, we are the standout second in the world population for diabetes mellitus. We are backing for China, which is the number one right now, but soon we may overtake with the current prevalence percentage. 40 million or more are living with diabetes mellitus. The rise in number is due to a lot of reasons. Few among them is one, the reduction in the physical activity, increased availability of processed foods. We know that a lot of food chains have come up, and we have an increased availability of the fast food era right now. Aging of the population, we try to see a lot of aged people, and they have a lot of comorbidities. For example, hypertension, dyslipidemia. We know that every comorbidity of a non-communicable disease is going to be interlinked once again. Obesity and overweight, obesity per se, there is a tremendous 300% increase in the obesity from the National Family Health Survey that we had into 2021. So the increase in the percentage of obesity is also on the higher side. So both obesity and the the sedentary lifestyle, as well as the availability of food, they are contributing for an enormous increase in the diabetes mellitus. Next slide. So the perception is that the lifestyle is the main fact. Next, yeah. So additionally, we have a lot of additional factors that can promote the increase the risk of diabetes mellitus. The ICMR survey that showed that 69 million people are living with diabetes mellitus, and they are going to be in increased over the next 10 years or 20 years duration. By 2025, it is going to be interpreted as around 69 million. That is, from 40, it is going to be becoming maybe two times by in another 5 years duration. Next slide. So the number of people living with diabetes is going to be on the higher side. Why? We have a lot of under recognized people with diabetes mellitus, because there is a lack of general awareness. After the COVID, we see a lot of people checking the sugars, but before the COVID era, we don't have people looking at the blood sugar value as a important scenario. Lack of accessibility for the tools for testing. For example, the concerned labs, concerned devices, their availability, their checking standards, everything is not available at the rural level, even to the tribal people. The economic divide between the people, we have an urban, we have a rural setting, where the difference in the availability of the testings and the resources is variable. Scarcity of the health professional, of course. Now we have a lot of the medical colleges that have been set up, a lot of the health centers that have come up, but still we are unmet. We don't have the patient doctors relationship, the ratio that is available in an adequate fashion up to this particular moment of the time. The financial constraints also will be a huge burden, because we are the low income or middle income the states and in the world, but we don't have huge resources which are cheaper and readily available for us, so that we can use it for a right control. The social barriers, of course, when you say diabetes mellitus and when you go into the public's opinion about diabetes also, it's variable. Today I had seen patients who say that, sir, one of my relative have come up with the idea of going for a powder replacement than going for medication. Now the sugar is 499 today, and her HbA1c is 13.7, which is like she's had the onset within 3-4 years of duration. So we have a lot of experience in such a fashion. Social barriers, and now I will add on to this, social media also plays a huge role. Particularly YouTube, you have a lot of videos that have come up, and they have enlightened in a different fashion. So these are all the barriers that make the people into an uncontrolled state in diabetes mellitus in Indian population. Next slide. So there is a rural and urban divide. Basically, the this socio-economic burden. There is a divide. Particularly, when you look into the Lancet report, they had clearly shown that people with urban citizenship, they had a higher incidence, particularly among the urban. When you look into the socioeconomic status among the urban population, the low socioeconomic status in the urban population had the higher incidence of diabetes mellitus, particularly because they had the easy accessibility for the fast food. Their awareness was on the lower side. Again, the time to reach for the checking and treating everything was delayed by a huge number in people who are in the low socioeconomic status in in the urban population. So their availability, their reachability, everything is also going to be different depending upon the rural or urban divide. Next slide. So we need to keep it in mind regarding the socioeconomic status whenever we consider the treatment and we are going for the adequate strategy of treatment. When you go for the physician perspective, when you look into this graph, we can see that this improved study where they looked into the number of the testings that have been done. For example, when you look into the blood sugar testing, it has been done by 95 to 96 percentage of the people for diabetes mellitus. But when you look into the A1C, it is around 19 percentage. So that means A1C being an important factor that has been considered by the American Diabetes, American Endocrine, Canadian Society, Australian Society, every society, even RSSTA also gives the enough of importance about A1C as an important tool for diagnosis as well as monitoring. But we don't use it much because of the availability as well as the accessibility. Next slide. So we have underdiagnosed, underutilized parameters as well among the physicians. So how to manage when you have a diabetic people, particularly diabetic patient who are coming to your OPD, always talk to them regarding the diet and exercise. Keep an eye on the blood sugars regularly. Keep an eye on their BMI. Keep the eye on the complaints as well. Control the sugars, control the blood pressure, control the cholesterol. Take care of the microvascular, that is the end organ damage. Annually check the kidneys, annually check the eyes, annually check the heart. Lose the weight which a patient is on overweight or obese. Practice an important thing is the oral hygiene, because we see a lot of people with the gingivitis. That can be a morbid condition, because a lot of gingivitis means their uncontrolled nature can predispose for background chronic inflammation, which has huge impact in their well-being. So these are the things we need to practice for getting a better control of diabetes mellitus in people with coming to our OPD. Next slide. So treatment strategy. So initially you try to hit hard on the patients when they are younger, go subtle on the patients who are elderly. So initial combination therapy should be wise. It should not be like haphazard. Go by guidelines. Guidelines gives you these combinations which can be done early. So the novel medications that can be available at the very time is the DPP4, SGLT2, GLP-1, which are they have been the game changers in the treatment of diabetes mellitus, because we know and we have enough evidences even from the guidelines stating the importance of using these medications in the prime tool of treating type 2 diabetes mellitus. Next slide. So you have a lot of drugs available, but the two drugs that are the unique at this very present of time, the SGLT2 and DPP4, they can be told as the type 2 diabetes game changers. They can prevent the use of the other combination therapies. They can prevent the use of insulin. They can prevent the use of other secretagogues. They can prevent hypoglycemia. They have different modes of action. When you look at the De Franco's lecture, the ominous octet being the pathophysiological basis of type 2 diabetes mellitus, these two medications, they act independently, and they act they target 5 out of the 8 octet organs that are being the pathophysiological mechanisms. So SGLT2 acts by the renal, and DPP4 acts at the pancreatic and at the intestinal levels, both contributing for reduction in the fasting, postprandial, as well as for the body weight. So ultimately, they have been a choice when you're trying to use it for type 2 in this present scenario. Next slide. So this combination is safer, rapid, and they have a sustained benefit of glycemic control. They improve both the fasting, postprandial, and A1C. They improve the insulin resistance. They prevent the beta cell damage. They reduce the weight, reduce the blood pressure, reduce the cholesterol. Overall, it is found to be cost effective in our day to day practice. So
I
this
think
comes to the
we've come to the end of the presentation. That was actually a wonderful presentation, Dr. Varun Kumar. So, as we said, that in diabetes control, diet, exercise, everything plays a vital role. Now, if you see, many people are trying these keto diet, intermittent diet, and things like these. But could you throw some light on keto diet and diabetes? Because generally, keto diet is either low carb or zero carb with high fat, high protein. So basically, it's fully low glycemic variability foods. So generally, the sugar is not going to go up. But then, will there be a bounce back, or are there, because there are so many studies that shows arrhythmias with the keto diet because of the high fatty food, and they're at high risk of dyslipidemia and cardiovascular diseases because of the high fat content. So, can you just enlighten us about this?
Yeah. So when you look into the diet that has been prescribed by the associations, it's basically a medical nutrition therapy. They say you need to have a balanced diet as their recommendation. The recommendation is quite simple. You need to go for a balanced diet. But when you look into the role of keto diet in diabetes mellitus, again there are multiple studies regarding the keto diet. Particularly when you look into the age of onset of the people and the duration of diabetes, there again the studies have been very skeptical. They don't you go for the people who are more than 10 years duration of diabetes. They keep it simple. If you are early in the phase and if you are having a pre-diabetes or a mild diabetes, if the A1C is less than 7 or something, they go for the keto diet as an initial 6 months time. The recommendations or the studies have not gone up more than 6 months duration. So we don't have a clear cut, the advantage of using the keto diet on the long term. But for a reversibility, what we speak about the reversibility now more often, when you have a diabetes at the very beginning, if you want to control it early and get it on the reversed phase, if you have a diabetes less than 3 or 4 years duration, then you can use a keto diet for its reversibility. But once you reverse, you are supposed to keep an a balanced carbohydrate diet that is being recommended by the organizations. So they recommend 40 to 50 percentage minimum, and it can go up to 60 percentage if the patient is having requirement of higher level. So the recommended carbohydrate needs to be met out in the diet.
Yes. So, more than we saying that patients who have developed diabetes recently, we could even say that it will really help people, not the keto diet, in general, people taking care when they have the pre-diabetes, because having pre-diabetes, if they stay on a good diet, if they work out well, they have high chances of not turning out into a person with diabetes. Now that we have actually discussed with what goes in, now a small query about how it goes out, because most of the people with diabetes have constipation. Most of the patients who come to our OPD say, I am constipated. I have tried this tablet, Durcolax, Dulfolax, and the Crimafin powders, whatnot. They've tried everything possible on earth. And after that, some go for native medications. Few of them tell, I eat this, I eat that. But what would you say to people who come to you with complaints of constipation?
First and foremost thing, when they are constipated, I look at the neuropathic status of the people, because most of the time they are, at the severe form of neuropathy, or they are having uncontrolled diabetes mellitus. So the control is the most essential part. But while we are controlling diabetes mellitus, I always tell them regarding the importance of going for a high fiber diet, the fiber moving up to at least 25 to 30 gram if possible. Then if they are not able to palate so much of vegetables, then I try to use part of the fibers. Additionally, they can use they can increase the amount of water intake as well. Those are the simple strategies. We can use it for preventing constipation. But if they are constipated, then we can go for medication for the till the patient is getting into the control phase, and then going for a proper diet and regular exercise. Again, exercise is an important tool for improving the overall bowel activity as well. So these are the most important things we need to consider.
Yes. So now that we've looked into what goes in, what comes out, after the patient is comfortable after going out, I think most of the patients have the next complaint, because main thing that we see in the OPD is one, constipation. Next, I'm not able to sleep, doctor. These are the two main things that most of the patients come to the OPD saying. So, does sleep affect blood sugar? That is one part of my question. Number two, how could we improve the sleep for a person with diabetes or in general for a person?
Yeah. So first part of the question, it's very important whether sleep will affect the diabetes mellitus. Yes, of course. When you sleep, the emergency hormones, we say the cortisol, everything, adrenaline, noradrenaline, everything will be on the growth hormone. Everything will be on the lower side. Because of that, our the metabolism shifts towards an going for an anabolism. So people will have a better fasting blood sugar control if they sleep well. Second, their fluctuations will be on the lower side. So the glycemic variability is also noted to be on the lower side if the patient is on a good sleep for at least 6 to 8 hours duration. And the timing is important because the sleep between 1 to 4 a.m. in the morning is considered as the best hour for the REM sleep. So sleeping between these hours and essentially without any interruption is very essential for a proper control. Coming to the second part of the question regarding the sleep hygiene, basically, when you're, before any medication, this is the basic thing we need to ask all the patients, irrespective of the diabetic status, any people who are coming with sleep issues, either the onset or latency. We are supposed to tell them regarding the switching off all the blue screens, that is mobiles or laptops, at least 1 hour before going to sleep. If they want to hear some music, they can have a light music rather than going for huge sounds. And their meal should be at least 1 to 2 hours before going for the sleep, rather than eating and immediately going for the bedtime. Second, they should avoid coffee caffeinated drinks at least 2 3 hours before going for the sleep. So these are the prime thing. Then they should go for the sleep, and they need to at least remain in the bed for at least half an hour before deciding that I'm not going to have a sleep. Few, they may go for the bed and they come out saying that I'm not able to sleep. Second, their amount of water intake, very essential, because now people, when they don't drink in the morning, they try to they compensate by drinking liters of water in the night. So better they should avoid going for a huge amount of water. They can stay with wetting the mouth rather than going for a huge amount of water intake. So these are things that can help to improve the sleep hygiene. Then the assessment for sleep medicines can be decided upon the patient.
Yes. Nice point to be taken. That is switching off all the phones, blue lights, and etc. over sometime before the sleep. But patients can bear with us on Fridays, because 4D sessions we do at 9 p.m. on
Nice.
Fridays.
Yeah, it's true.
So I think they can bear with us a little, because this is for the public cause. So now that we have done with the sleep, constipation, what goes in, the next main key factor in diabetes control is exercise. So what type of exercises can people with diabetes do?
The basic idea behind exercising is basically the aerobic. We know that the exercise between an aerobic exercise and the weight training exercises. So isometric exercise and aerobic exercise. But the recommendation is always towards an aerobic exercise because the metabolism is much better and superior, and the glucose utilization will be on the higher side. That's the main reason for utilizing the aerobic exercise in the prime aspect. So the recommendation is going for the 150 minutes per week as the international guidelines, but the usual spaces go for 30 minutes workout every day in the preferably empty stomach in the early morning, or at least the every day, preferably every day a week without any rest, because when people go for a rest, they try to lose the intensity of working out. So that's a basic problem. The type of exercise, when I say aerobic, it can start from a simple jogging, sprinting, walking, or swimming, or any of the outdoor exercises that will improve the heart rate. Again, the heart rate will be the prime factor to decide regarding the the intensity the people is working on. So the heart rate should be the ultimate goal, and it depends upon the age of the patient as well. So that will be the ideal idea behind the instituting exercise therapy for a patient.
Yes. So now that we've looked after a patient's diet, sleep, exercise, all this, we move on to the main part, because definitely diet, exercise, sleep, everything is very important. But most of all, treatment is also important. So we've got the latest drugs, the SGLT2 inhibitors coming up. We've got many other molecules like the DPP4 inhibitors. We've got the sulfonylureas, etc. So how is the SGLT2 inhibitors when we are comparing it with the DPP4 and the sulfonylureas? What's so special about the SGLT2 inhibitors that everybody is talking very lately?
So this SGLT2 as a class actually has been looked upon after the EMPIRIC outcome trial that came in 2011. So what it changed the phase is initially the FDA wanted some safety data for using medications, but when they started looking at the trial outcomes, they noted that more than safety, it had actual benefit in terms of reducing the cardiac related effects. For example, they reduce the hospitalization, they reduce the cardiac death, they reduce the overall death for any people treated with empagliflozin. So that's how the SGLT2 as a class, they have been shown the benefit in terms of prevention of the cardiac, the morbidity and mortality. Moving further, when they looked into the renal data, now we have seen that the renal benefit is also well proven in terms of reduction in the progression of the renal disease. New onset of disease is prevented. Second, the chances of patient developing the dialysis or developing the transplantation, requirement of transplantation is also reduced by huge numbers. So the advantage is not just the getting the sugar, but under control. It also provides a huge benefit for prevention of the microvascular disease. That's how the SGLT2 as a class have been coming up in the practice of diabetes mellitus.
So, which are the class of patients would you choose these SGLT2 inhibitor molecules in your clinical practice?
Yeah. When you go by the guidelines, it's very simplified, and we have the guidelines stating if your A1C is more than 7.5, not controlled on metformin in a type 2, then we can choose the agents depending upon the patient's overall cost of preference, their weight status, their the atherosclerotic cardiovascular disease or risk. So SGLT2 will be in the prime spot. So in my clinic, I use it as by the guidelines in most of my practice. In my most of the people with type 2 diabetes mellitus. Either I use it as a add-on with metformin or use it as an add-on with a DPP4 inhibitor, so that the additional benefit is being achieved for the patient. Second, in patients with insulin also, I use it for reducing the overall A1C percentages. And the benefit is clearly noted in terms of improvement in the weight as well as for the cardiovascular benefit.
Okay. So, is there any set of patients that you're supposed to avoid this SGLT2 inhibitors?
Yeah, definitely in patients who have come with an acute infections, particularly an UTI or prostatitis, or the patient is having renal nephritis, or pyelonephritis, or something like an infection around the GI genitourinary tract. If the patient is having, it's relative, but patient is having genitourinary vaginosis, then again relatively you can stop it for some time till the vaginosis is cleared. If the patient is having EGFR of less than 15, if the patient is not able to take the medication due to the patient's overall increased thirst. For example, elderly, some of the people, they may not tolerate using SGLT2 inhibitor. In them, again, we can avoid these using medications, or you can use it as the lowest possible dose. These are all relative contraindications in an hospital setup, particularly if acute infections, ICU. Definitely, we are supposed to stop these SGLT2 inhibitors. Otherwise, routinely, we can use these medications, particularly if the patient is thin built and if the patient is on insulin. If the patient stops insulin, we need to stop SGLT2 also, because the chance of euglycemic ketoacidosis also will be on the higher side. So most of the conditions will be relative. Definitive contraindications not as available in most of scenarios. If they have recurrent UTIs, again, it's a relative contraindication. But even if you stop and restart, few of the patient will, accept the use of the SGLT2 as well.
Okay. Now that we have spoken about treating diabetes, about diet, complications, all that, we come to the main part and the final part of our session for today. Because, okay, treating diabetes, everything is fine, but let us talk little about prevention. That is, before even we could stop, always prevention is better than cure. So we've always spoken about diabetes complications, people coming to us. But what is the small message or something that you can tell people regarding prevention? How can they prevent themselves from developing diabetes? Who should be careful that they will be high risk of developing diabetes?
The most essential thing is a family history. If the people, maybe who are pre-diabetic or non-diabetic, if they come to you, if the family history is strong, maybe the grandparents starts from the grandparents. If their grandparents or parents or siblings are having diabetes mellitus, definitely these are the age groups. These are the people group. They need to be very careful, because the risk is going to be higher with every the member of the family getting into diabetes mellitus. Second, if they are on medication that can increase the risk of diabetes, for example, the particularly rheumatological conditions where you have increased use of steroids, increased use of medications like the asthmatic medications, those the chronic diseases, chronic medications that can increase the predisposition for diabetes mellitus. Second, sudden increase in weight or obese people who are going for consultation for the other non-communicable diseases like hypertension, dyslipidemia, or the patients on the statins, which are having a mild risk, but still the risk is going to be a bit on the higher side. So people who are having thyroid illnesses, particularly hypothyroidism, even hyperthyroidism also can contribute. Second, if the people are, the pregnant women who are overweight or obese, their risk of getting into a phase of the diabetes mellitus is going to be in the higher side. If the mother had gestational diabetes mellitus, their chance of developing the over diabetes mellitus is by 65%. So they're also the risk group that we need to go for treating. Young people who are overweight, obese, if they are taller, if they have PCO, particularly in the adolescents, they are the people who are at risk of developing future pre-diabetes or diabetes mellitus. So these are all people group that we need to focus on prevention.
Sure. So, with this, we have come to the end of our session. I think we had a wonderful session and knowledge about different drugs and constipation, sleep, and prevention. So, it was wonderful having you, Dr. Varun Kumar. Thank you.